Hi everyone, thanks for listening to all my presentations. Today I'll be rounding up on hepatitis C virus infection, and I'll be limiting my presentation today to the treatment of hepatitis C virus. There is a saying that a stitch in time saves 9. All I'm out to do is to create the awareness that you don't have to die, particularly when you can get screened and you can get treatment. If you have listened to my other presentations on hepatitis C virus, you'll be able to follow up with your doctor to have yourself screened for hepatitis C virus if you belong to the group that I've listed. And of course, open the conversation with your physician. Now, there are a lot of medications that your doctor could choose from, and a referral could also be made to the specialist. So, why suffering in silence? Why would hepatitis C still be causing suffering and even be killing some other people when it is preventable? When there are so many medications right now that your doctors could use. In the course of this presentation, I'll do something different. I'll pause, you look at medications yourself, and then I'll move on. So, let's go. Before we commence treatment of hepatitis C virus at all, we need to take into account certain factors. Number 1, the genotype of the hepatitis C virus. Those who have listened to my presentation on the screening and diagnosis will know that I've mentioned the fact that determining the genotype of the hepatitis C virus will be very, very critical to having a definitive and correct treatment of hepatitis C virus. Then we need to consider the patient status, either young, old, immunocompromised, or immunocompetent, decompensating liver, or compensating. We need to know whether there's liver cirrhosis or not, any comorbidity or not, like is there co-infection with HIV? Is there co-infection with hepatitis B virus? We need to know all this. Then we'll make up our mind whether or not we will need Peg Interferon or we will need Ribavirin. Now, the full journey into the treatment of hepatitis C virus begins with hepatitis C virus genotype 1 and treatment naive. Let me explain. The genotype of hepatitis C virus has been determined, and it is genotype 1. And this individual had never been treated before, so he or she is treatment naive. Then we will ask ourselves certain questions. Any liver fibrosis going on here? Any liver cirrhosis that is decompensated? If the answer is that there's liver cirrhosis that is already decompensated, then we'll give antiviral agent right now, and we'll send referral to the specialist to handle this. And then you'll be following up after. If there is no decompensation and the genotype is still subtype 1A, we will do something different. Remember, if there is decompensation, we will pick antiviral agent and then refer to the specialist. Now we have the privilege of doing more stuff because the situation is not yet horrible. So we will stage. We want to know the stage of the fibrosis, its severity in hepatitis C, and we will use meta-V. That means meta-analysis of histological data in viral hepatitis. The grade will indicate the degree of inflammation, and the stage will represent the level of scarring or the level of fibrosis. And meta-analysis of histological data in viral hepatitis will also help us to predict the risk of hepatocellular carcinoma. Now, as far as fibrosis cause is concerned, we have F0 to F4, with 0 being no fibrosis, 1 meaning portal fibrosis without septa, 2 means portal fibrosis with few septa, F3 means numerous septal fibrosis but no liver cirrhosis yet. F4 means, the end of the road as far as fibrosis is concerned because we now have liver cirrhosis. Right here are few examples of some of the antiviral agents that will be used. And I will let you go over them yourself. I'll just pause and you have a look, but I'll say a few things, then I'll pause. Examples of NS5A are the following. You can look at them later on. The non-nucleoside NSB polymerase inhibitor is dasabuvir, and a strong NSSA inhibitor is umbitazva. Then, the one that has been with us for a long time is NS5B inhibitor, that is sofosbuvir. If the outcome is between meta-V F0 to F3, meaning either no fibrosis or numerous septal fibrosis, but no liver cirrhosis of any kind, then we can choose any of these three regimens. I will pause a bit. You look at it yourself. If the situation is that there's liver cirrhosis, but not decompensated, that is, we are dealing with meta-V 4, then we can choose any of the regimens found under F0 to F3 on the previous slide. Then there could be the opportunity to choose another regimen entirely, which will make it the fourth as this. Then I'll pause now, then you have a look at it. Times 16 here means for 16 weeks. 16 over 52 means 16 weeks. Okay. If not decompensated, but it is subtype 1B, and then the fibrosis score is revealing no fibrosis up to numerous septal fibrosis, but no cirrhosis. remember this is now subtype 1B. We can use the regimen under F0 to F3 type 1A. Okay, we may choose the fourth one as Ribavirin plus Grazoprevir for 12 weeks. I may choose the fifth one as Untitled plus Pariprevir plus Ritonavir plus Decompensated for 12 weeks. Now, cirrhosis and it's type 1B. That is F4, right? We can choose what we have under type 1A, F0 to F3. We may then choose the fourth and fifth of F0 to F3 type 1B. So you can rewind to see what has been listed under type 1A, F0 to F3, and what has been listed under type 1B, F0 to F3. And remember, anything I put over 52 means the number of weeks. For example, 12 over 52 means 12 weeks. Genotype 1, but treatment experience. Remember, I've just finished with genotype 1A, 1B, treatment naive. Now we are dealing with an individual that is not new to hepatitis C virus and not new to the treatment of hepatitis C virus. Just as you may have when you are choosing medication to treat pain and you are dealing with opioid naive or opioid tolerant. In this case, this person is familiar in one way or the other with the treatment of hepatitis C virus. Probably been given medication in the past like Peg Interferon, Ribavirin, and so on. Now, we'll go over the Medivir F0 to F4, and then we'll determine the treatment history, and of course, whether it's subtype 1A or 1B. Okay, we want to know whether there is decompensated cirrhosis. If it is decompensated cirrhosis, then we have to commence antiviral agents with consultation to the specialist. Okay? This person is treatment experienced and the genotype is subtype 1A, but no decompensation. Then we will ask, what treatment have you been given in the past? If the individual had taken Peg Interferon with Ribavirin only in the past, then we can use anything under subtype 1B. Okay, you can rewind and get back to it again. We may choose the fifth regimen under the situation that is subtype 1A in experienced individual that is not having decompensation and are taking Peg Interferon and Ribavirin only in the past, then we can give all this right now for 12 weeks. If there is liver cirrhosis, but there is no decompensation, then we can use either of this. I know most patients and doctors are familiar with Subtype. So there are a lot of other combinations right now. If we're dealing with subtype 1b in an individual that is experienced who had used Peg Interferon and Ribavirin only in the past, but no cirrhosis, then we can choose treatment under 1, 2, 3, and 4 of subtype 1A naive. To some people, this is complicated, right? Unfortunately, I can't be going over the entire list all the time, so you can just maybe you screenshot, you get what is under type 1A naive, what is under type 1B, and then you'll be matching it as we progress. If liver cirrhosis is present and is subtype 1B, we can choose any of these regimens. Remember, anything over 52 means the number of weeks. Anything over 7 means the number of days. If the affected individual had been placed on protease inhibitor with Peg Interferon and Ribavirin in the past, but no cirrhosis right now, then you can choose any of these regimens. But if there is cirrhosis, then the regimen can change to what we have here. If past regimen contains sofosbuvir or NSSA inhibitor, that is non-structural protein 5A or 5B, then we can now use sofosbuvir, bebatazvir, vosilaprevir, plus glecaprevir, and pibrentasvir. Okay, we are done with genotype 1. Now we are dealing with hepatitis C virus genotype 2 infection. Then we have to get the stage of the liver fibrosis. We'll take history of past treatment and we'll find out whether there's decompensation or not. Then, if not on any medications before and there's no liver cirrhosis, then we can choose either A, B, or C below. If not on any medications before, but now done with liver cirrhosis, then we can choose either A or B below. If the individual has been treated in the past and it has failed, for example, if the person has been given sofosbuvir before and it has failed, then you can give sofosbuvir with bebatazvir for 12 weeks right now, or you choose ribavirin, sofosbuvir, and daclizazvir for 24 weeks, and you may choose the first combination. If the issue is the failed NSSA 5A or 5B, then you can give sofosbuvir, bebatazvir, Viral for 12 weeks, or Sofosbuvir, Hepatitis plus Ribavirin for 24 weeks. We are done with hepatitis C virus genotype 1 and genotype 2. Now is all about genotype 3. We will observe all protocols like we've done under 1 and 2. History, physical examination. Of course, genotype is determined right now, and we'll get the metaverse score to know the level of fibrosis. If it is decompensated liver cirrhosis and is genotype 3, consult to the specialist with guidance to choose the appropriate antiviral agent and other interventions after. If there is no decompensation and the individual is treatment naive, we can choose glycaprevir with pibrentasvir for 8 weeks or sofosbuvir with velpatasvir for 12 weeks. If it is compensated liver cirrhosis and NSSA RAS test is Y93H, NSSA RAS means resistant associated substitution, and Y93H is a genetic mutation of that. If that is absent, if there's no genetic mutation with Y93H, then we can use the above regimen and we treat as a naive and not compensated. But if the genetic mutation with Y93H is present, we will change the regimen to include Ribavirin with sofosbuvir velpatasvir for 12 weeks, or daclizumab plus sofosbuvir with Ribavirin for 24 weeks. If this is type 3 and has failed Peg Interferon plus Ribavirin, now compensated liver cirrhosis, then we can choose any of this. I'll pause. If there is no cirrhosis, but Y93H is present, then we need to test for NSSA resistance associated substitution. Then we can choose any of the following. I'll pause and you can have a look. If there's no liver cirrhosis, but Y93H mutation is also absent, then we will test for NSSA RAS and choose any of these three. If the history is essentially that there was failed past antiviral and also failed NSSA inhibitor, and now with liver cirrhosis, then we can choose sofosbuvir with velpatasvir with viral plus Ribavirin for 12 weeks. Finally, if this is a failed past direct-acting antiviral, but no failed NSSA, and now having liver cirrhosis, then give sofosbuvir with Hepatitis and Previr, all for 12 weeks. And with that, I've come to the end of this long and boring presentation. Yes, I will admit it could be boring. And with that, the names, the different and difficult names of the antiviral agent. You know what? It is better to have this information and have so many lives saved, or at least reduce suffering in a lot of people. Now, I'll end where I started from. A wise saying says, a stitch in time saves 9. If you are suspicious that you might have been in contact with someone with hepatitis C virus, maybe by virtue of your profession or by the nature of your lifestyle, or because of ailment and you are on hemodialysis for a long period of time, then walk to your doctor. You might be on the screening list and have your hepatitis C virus status determined. It might not be your fault altogether. Might be you were transfused with blood before 1992, or you were born within certain years. Please just don't take that risk, because the complications of hepatitis C virus are horrible and then may cut your life short. And the essence of my presentation is to bring awareness to everybody that you don't need to be suffering unnecessarily, and we have to work together with the physicians, the nurses, to reduce death. Therefore, don't let this campaign end here. Let it start from now, spread it to others, because there are so many people with hepatitis C virus. Now, treatment with so many different antiviral agents are available. You could see the gamut of medications we've gone through. So why would someone then be dying like chickens without a good breeder around? No, should not be. Help yourself, help your friends, help everyone on your platform. Share this information. Remember to subscribe as well. I appreciate it. Wishing everyone affected well. Again, a stitch in time saves 9. Thank you.